Hi, everyone, and welcome to today's Pulmonary Fibrosis Foundation Disease Education webinar series. I'm Dave Lederer. I'm a pulmonologist in New York and a medical advisor for the Foundation on Education. Today's webinar is on lung transplantation, and I'm thrilled today to be joined by Dr. Timothy Whelan, Professor of Medicine and Medical Director of the Lung Transplant Program at the Medical University of South Carolina. Welcome, Tim. Dr. Whelan's disclosures include clinical research funding from the entities noted here, including the NIH, the Pulmonary Fibrosis Foundation, and a number of pharmaceutical companies, as well as funding for consulting and research unrelated to this current content. Now, I do want to make one notation here. This is an important disclaimer that none of the information that you hear today should be interpreted at all as medical guidance, as medical advice, or medical recommendations. We are only providing information on lung transplantation, mostly as it relates to pulmonary fibrosis, and you should absolutely discuss any concerns or questions that you have with your physician or nurse practitioner or other healthcare provider. Now, before Dr. Whelan opens, I am going to reinforce some of the take-home points about lung transplantation that are, I think, really going to be the fundamental issues that you walk away with. Number one, lung transplantation can provide a second chance. After pulmonary fibrosis has progressed significantly, lung transplantation can be a very appealing option that can prolong life, improve quality of life. As you're going to see throughout the presentation, transplantation also has limitations. And as you'll see, these limitations include problems with complications from medications, which include things like diabetes and kidney disease. Transplantation also can increase the risk of infection, and that includes not only infections in the new lung, but infections anywhere in the body, ranging from very mild to much more serious and even life-threatening. Many of you have probably heard about rejection. So that includes acute rejection and chronic rejection that you're going to hear about. You're also going to hear about the evaluation process, which takes a long time, and as you'll hear from Dr. Whelan in a moment, that means that referral to a transplant center in that very first visit has to take place early in the course of disease to give you enough time to be thoroughly evaluated. And then you're also going to hear a lot about the variability in transplant practices across the not only just the country, but across the world. So, Dr. Whelan, are you ready to take over here?
I am now ready to take over. Thank you. You did an excellent job while I was stressing out trying to dial in. Thank you.
No problems at all. Thrilled that you're here, and I'm going to let you take it away.
Good afternoon, everyone. So what I'd like to do is give a little bit of the history of lung transplant, and then kind of stepwise go through, I think, some of the common pathways that patients with pulmonary fibrosis can hear more about transplants, and then some of the ways that I think you can actually really help us take better care of you. So, lung transplants, the first lung transplant was actually performed in 1963 at the University of Mississippi. That patient was a lung cancer patient. He underwent the transplant, and he lived for about 18 days, and he died from complications of the immunosuppressant medicine at that time. And so the main immunosuppressant that they used back then was prednisone, and the patient developed severe infection and then all of his organs failed 18 days later. But that was truly the first attempt at transplant that managed to live beyond 24 hours. There were many attempts between 1963 and 1981. There's about 40 attempts that are published in the literature, and unfortunately, those were unsuccessful. Gustav, the monkey that's pictured there, he is actually a heart-lung recipient and one of the first heart-lung transplants that was performed successfully in animals, and that was in 1981 by Dr. Reitz at Stanford University. And that was with the advent of a new medicine called cyclosporin, and that is truly what changed our ability to be able to pursue thoracic transplant. So in 1983, Dr. Cooper in Toronto did the first single lung transplant. That single lung transplant patient was a pulmonary fibrosis patient and lived about 5 years and had good quality of life during that time. And then in 1990, when things were still pretty early in lung transplant, there were about 255 lung transplants that were performed, lung and heart-lung transplants that were performed in the United States. Of those, about 50 of them were heart-lung, so about a fifth of the transplants were heart-lung transplants. The other 4/5 were lung transplants. In 2017, just finishing up this calendar year, we've increased that tenfold, done nearly 2,500 lung and heart-lung transplants, but the real difference is that the vast majority of those are lung transplants. Heart-lung transplant is actually a fairly rare event. There were 29 in 2017, and that was actually a lot. That was a bigger year for heart-lung transplants. Typically, oftentimes it's about half that number. So lung transplant outcomes, as Dr. Lederer mentioned, we have some real challenges. The immune system recognizes that new lung as a foreign body. So similar to when your body recognizes that you have an infection with a virus or a bacteria, your immune system will get revved up and you'll try to get that out of there because it's not supposed to be there. The result of that is rejection. Acute rejection is actually very common in that first year after transplant, while chronic rejection typically happens much later, and I'm going to talk about those in a little bit. Because the rates of acute rejection are so common, we do need to do things to correct that or prevent that, and the major way that we do that is to suppress the immune system. As a general rule, immunosuppression is much greater immediately around the time of the transplant than it is 1 year after transplant or 3 years later. But also, as a general rule, lung transplant centers typically use 3 medications: tacrolimus, mycophenolate mofetil, and prednisone. And these are tacrolimus is a cousin, if you will, of the medicine I mentioned earlier, cyclosporin, the first medicine that allowed us to do transplant. The majority of centers use these 3, and there's some variations on that, and then physicians may target different aspects of the immune system with other medications, but as a general rule, these 3 medications are very commonly used for lung transplant recipients. And as was mentioned, these 3 medicines do increase the risk of other problems, and unfortunately these other problems do come along with lung transplant, and they include the risk of infection. So if we suppress your immune system, that's going to make you more likely to develop infections. The common side effects of particularly tacrolimus and prednisone are high blood pressure and diabetes, as well as kidney problems. Fortunately, the kidney disease issues tend to be at a level where perhaps the physicians are adjusting medications because to make sure that they don't overdose the medicines inadvertently. It's a relatively rare event for a lung transplant recipient to go on to require dialysis. but also it is equally true to say that the longer that someone is exposed to these medicines, the more likely that the chronic kidney disease can be more severe. So for individuals who do very well after a lung transplant, if they're 10, 15 years out from transplant, that chronic kidney disease can be a challenge for people. Osteoporosis or thinning of the bones is very common, and cancers are also very common because one of the ways that your body prevents you from developing cancers is your immune system cleans those out of there. So if we suppress that mechanism, you're at increased risk. Typically for a lung transplant patient, it would be skin cancers because those are very common, but unfortunately all cancers are at an increased risk. And so when we talk about things that we do to evaluate patients, cancer screening as part of your health maintenance, that's one of the biggest reasons that's so important to us. So how are we doing? We've been doing transplants for about 35 years now. So what's the lung transplant experience in the United States? So as I mentioned, we do about 2,500 lung transplants in 2017. This data is just a little bit older than that. And this graphic on the vertical axis is the number of transplants. On the horizontal axis is the number of years, and that's important because I'm going to show you that you can see that it looks like some things uptick on this graph, and I think that that's important. It's showing that we're doing more and more transplants. Over here is the group. So the way that we list patients in the United States is we assign them to a group, A, B, C, or D. So group D, which is this line right here, those are patients with interstitial lung disease and pulmonary fibrosis. So the majority of transplants that we do in the United States is in this group. The next most common group is group A. Group A is patients with emphysema. And then group C is cystic fibrosis patients, and group B is patients who have pulmonary hypertension. So we're going to start talking a little bit about outcomes, and when you think about how a patient does after a transplant, there are factors on both sides that can impact on how an individual does. So the donor's age does matter. An older donor can place those potential lungs at risk. Ischemic time, or how far away those lungs are from the center and how long they're off a blood supply, can impact on how a recipient does. And then also the function, or how good are those lungs, kind of makes sense that if we have really good lungs that have absolutely no injury in them, they're more likely to do better, particularly early on, than lungs that maybe have a little bit of injury. The tough part in this discussion about these risk factors, though, I will tell you, is that donors, there is a broad range that we think are acceptable. So some of these factors do influence outcome, but as a general rule, centers are choosing lungs that are quote-unquote good lungs. We think that all of these lungs are going to do well in a recipient. If we did not think that, we wouldn't take them. Recipient age does matter, so I'm going to show some outcome data about age, and then the recipient's diagnosis, and then how sick is the potential recipient. Is that recipient in the intensive care unit, on a ventilator, versus being out and actively participating in pulmonary rehab? Those factors do influence how patients will do. So this is data. I'm going to show kind of two different types of data to show that it's consistent. This is data from the United States, so this is our SRTR data, and you can see this is separated by age. So again, each color is a different age group over here. So as a general rule, pulmonary fibrosis tends to affect older patients, so folks over the age of 50. So this brown line here is individuals over the age of 65, and then this green colored line is the folks over the age of 50. So you can see that there's a difference between these two groups, suggesting that people who are older, right, they don't do quite as well. Because again, so I'm going to just explain how to look at this graph. So this is the number of people that are alive on this axis here. So if everybody's alive over time, it would be a straight line right across the top. As patients pass away, then there's fewer and fewer people that are counted, and so the line will fall. This particular graphic is over 60 months or 5 years. So from this graphic, if you could kind of average all this stuff together, which is this colored line right here, then more than 50% of the people are alive at 5 years. I'm going to show that in a slightly different graphic in a second here. So the international experience, which includes a lot of data from the United States, but also includes Europe, Australia, the whole world that is doing lung transplant is participating in this registry. This graphic, it separates by men and women, and you can see they do similarly. And on this graphic, if you look at the median survival for transplant, it's a little bit longer for women, but it's right around that 5.5-year mark. So this tends to be the number that physicians will tell folks, is that the average survival after 5 years, the average survival of a lung transplant recipient is 5.5 years. So to just take a second and talk about what that means. So an average survival means that if I transplant 100 patients in 5.5 years, there'll be about 50 of those folks alive, and 50 will not be. So that's very different than saying if you get a lung transplant, you got about 5 years left to live. No, half of the folks are going to live longer than that, and half of the folks, unfortunately, are not going to live that long. So the next graphic, and I'm going to kind of, it did automatically slide my slides down. So the next graphic is talking about the differences between how patients do over the years. So as I mentioned, we've been doing lung transplant for about 35 years. And over that time, we have improved. So the cohort that was transplanted from 1990 to 1998 is this blue line, and the most recent cohort is the red line. So we seem to be inching up and getting better. I really wish that this line would go straight across the top of the paper. That would be awesome. We have some real challenges, and I'm going to talk about those in a minute. And then the last slide is just again demonstrating that depending on what the diagnosis is, that also influences your outcome. So again, if everybody was alive over the entire time, it'd be a straight line across the top. If that line is falling faster down the paper, then that means that they are at greater risk to die sooner. So for folks who have a diagnosis of IPF, which is right here, this white line, they're kind of right here in the middle. You can see that they're not, they're doing better than some other folks. Retransplant, which is this purple line, is a tough procedure for a lot of folks. So as a general rule, when I'm talking about this, I tend not to really get bogged down in the differences between the diagnoses, because I do think that there are a lot of factors that influence this. So including your age, including your functional status. And so I tend to talk to patients about that you've got a 50-50 shot of making it about 5.5 years. I think the importance of that number is to just understand that there's real limitations. I also think it's wiser to try to be really positive and think you're going to have a good outcome. I think that there's nothing bad that can happen from that. And I actually think it can really keep people motivated to work hard, because it is hard work after that transplant, particularly early. So how are our patients doing? So this is a way of looking at how the centers, the transplant centers, scored the functional status of patients. So an individual with a functional status of 80%, which is this up to this green bar, it's everybody up to this top of this green bar, means that you're living independently, you don't have any limitations, and that you can work. So that is a very functional person. 1 year after transplant, you can see it's about 75% or so, and then it kind of goes up a little bit for years 2 and 3, right around 80%. This 70% block, people who have a 70% functional status, they are still independent, but they do have some limitations. So the vast majority of patients that we transplant are able to live independently following the procedure, but unfortunately not all of them are completely asymptomatic and able to go to work. Another way of looking at this is saying, well, how many people actually do go back to work? So a lot of our patients are older, so you can see that folks in this big yellow box here are retired. And then there's a smaller box of people that are working full-time, people that are working part-time, and then people whose status that we don't know. The not working group, you can see, is a pretty large cohort. I think that this is a complicated slide to look at because I think that there may be other reasons that people are not working. It may be difficult to get a job if you have a chronic medical illness, and so employers may not opt to hire you. That is a possibility. And then some insurance things, particularly in the United States, can be influenced by what one chooses to do for work, so that can impact on that decision. But general rule, most of our patients are not actively working following transplant. And then rehospitalization. So rehospitalization is another way of trying to get at this idea of how do patients do. So the red box means that there was no hospitalization during the previous year. So you can see in the first year, getting hospitalized, it's more than half. It's about 60% of our patients will end up back in the hospital. The vast majority of those patients, it's a short hospitalization for a correctable problem. As you get to 3 and 5 years out, there's still a real risk that you can get admitted to the hospital. It's as much as 40% of the folks. And as I start talking about what kinds of challenges we have late after transplant, that explains many of those hospitalizations. So early after transplant, comorbidities do come along. So comorbidities is another way of saying other illnesses that you have to work on, so besides the lung transplant. So up front, folks tend to be real sick. They're in the ICU at least for several days, but they're at real risk to get very sick with the transplant. Deconditioning is very common because most of the patients that we transplant are very sick and limited, and significantly limited, so they're weak even when their lungs are working great immediately after transplant, so we do have to do rehab. Acute kidney injury, so an injury that happens around the time of the transplant outside of what I mentioned earlier with the medications, that's actually really common. And so occasionally it can be a severe acute injury that can hold people back for a bit. And then, again, that risk for being hospitalized in that first year is a real risk. Later after transplant, that list that I mentioned earlier, those problems become a bigger issue. So the risk of high blood pressure, diabetes, kidney problems, bone problems, and then the chronic immunosuppression can increase the risk of cancer. So the last problem that I want to spend a minute or two talking about is chronic lung allograft dysfunction. So that is a long way of saying that after the lung transplant, patients develop a process that is an immune-mediated process. We think it's different than acute rejection. So acute rejection is really common in that first year after transplant, and typically if we increase someone's immunosuppression, we can make it go away. So that's a very treatable problem the vast majority of the time. Chronic lung rejection or chronic lung allograft dysfunction, on the other hand, is something that tends to happen later after transplant. It's very common. It results in shortness of breath. And in its classic form, the breathing tests look exactly like an emphysema or chronic bronchitis patient. You get shorter breath. You can end up on oxygen. It has a variable clinical course, so there are some people that have kind of a slow marching out course. There's some people that we see a drop in their breathing test and it can stay stable for a long time. And then unfortunately there are also others that can have a rapid decline. Our treatment options as a general rule for this problem are really limited. And this problem of having declines in lung function really increases the risk of individuals to particularly develop lung infections. So the top two causes of death late after transplant are this chronic lung allograft dysfunction or infection. And I think it's a clouded issue. Patients are very high risk to develop pneumonias when they get this problem. So let's talk about the positives, though. So those are all the challenges to transplant, but let's talk about why we think that this is a good idea. Well, we get rid of that supplemental oxygen. It is truly one of the most amazing things to see someone go from requiring a ventilator to be able to be alive, to coming off of the ventilator and being on room air. It is truly incredible. Patients, again, are independent. So prior to transplant, our patients are on oxygen and often have very significant exercise limitation. After transplant, the vast majority of folks are living independently, able to live out their daily lives, make their meals, and be truly independent. And because of that, the quality of life consistently has been shown to be better for individuals who are transplanted compared to individuals who are actively awaiting a transplant. And last, and not to be discounted by any means, is that there is a survival advantage. The tricky part about survival advantage is you have to be able to get through the hoops to be felt to be a good transplant candidate. So for individuals who have pulmonary fibrosis that go through the process and are felt to be good candidates for transplant, get listed for transplant, and undergo a transplant, those individuals will live longer because they had transplant compared to individuals who do not undergo a transplant. So this gentleman, his name is Lorcan. Lorcan is one of my patients. He is now 7 years almost 7 years post-transplant, and he still looks very much like this happy fella. He's holding up his certificate there that he completed a 9.5 mile race. He is definitely unique. He was a very active athletic guy before we transplanted him, and he has chosen to keep that as part of his lifestyle. But I would argue he's a very happy, smiling guy who's doing great, and despite those things that I mentioned, clearly has garnered a benefit from transplant. Lorcan, on the day that we transplanted him, he was using 100% oxygen and was profoundly, profoundly ill. So transplant is a good thing. So who do we consider for transplant? Well, I think it's important for you all as patients to know and understand the kind of things that the physicians are looking at and thinking about, not only so that you can better understand some of the things that they may say to you, but also so that you can help them, like I said, be better doctors by asking, hey, so what about this? So the referral criteria for transplant, this is from a consensus statement of transplant physicians and surgeons. And one of the criteria that we put in there is that if individuals have a diagnosis of IPF, they really should be considered for referral for transplant. Similarly, if their breathing test, their forced vital capacity is less than 80%, or if their diffusing capacity is less than 40%, if they require any oxygen, not oxygen only at rest, but if they require it with exertion, we think that that's a group of individuals that we ought to start having conversations with. And for other pulmonary fibrosis diseases, particularly inflammatory lung diseases, those are diseases that oftentimes we will try to treat with different types of medications. If those medications are not working, or if someone is progressing, we think that that's an individual who should be referred and that there should be some discussion. So we have never really been able to figure out exactly how good doctors are, how adherent they are to these recommendations. So we tried to do this using our IPF Pro registry, which for this particular data set, it was 18 centers that are interstitial lung disease centers. Many of them are part of the Pulmonary Fibrosis Foundation, including mine. And the first patient was enrolled in June of 2014, and where we took the data from was all the way through May of 2016. All of these patients, to get into the registry, they're well-documented IPF, so the center said, yep, they definitely have IPF. And what we enrolled over that time was 334 patients. And so we said, well, age is a tricky thing, and I'm going to talk about that a little bit later, but as a general rule, it's not likely that someone over the age of 75 is going to get a transplant, so we took them out. Individuals who are overweight and a body mass index of 35, transplant centers agree that that is too heavy for a transplant. And then if people are actively smoking, so we got rid of 108 patients, and we had 226 left. And then we looked at them and we tried to figure out, do they meet any of these criteria that this transplant group said you should send the patients to us? And we found out that there were 50 that really didn't look like that they met the criteria, or we didn't have the data to confirm it. That left us with 176 patients, so about half of the whole group looked like they should get referred for transplant, or there should be some discussion about transplant. And that is the major limitation in this data. I can't tell you if someone talked to them about it. I can only tell you if it was clear that they were referred for transplant. But you can see the vast majority of people were not referred for transplant. And so I think, although there's some challenges with this data, particularly answering this question, I think that there's multiple different possibilities. I think that people we may not have complete data, and maybe some folks were really too sick or had other problems that would preclude transplant. But I do think that this data is important for getting the message out that we really need to be talking to people about transplant. Make sure that they are aware of this option, and we really give everyone an opportunity to know what is out there. So this quote is a quote that I often hear from physicians when I say, really, I want you to refer patients to me. It's okay. And they'll tell me, come on, you don't want to see everybody. Well, there is some truth to that. It's very hard for me to see everybody. So there are absolute contraindications to pursuing transplant. This is kind of a long list, and rather than reading this out to you all, I will tell you that it kind of hinges on folks really need to have a high likelihood that they're going to do well after the transplant, and absolutely if there are other organ problems in someone, like advanced kidney failure or heart problems or other issues with chronic infection that can limit that outcome after transplant, as a general rule, lung transplant centers are going to be reluctant to pursue transplant as an option. I put this particular one in italics because this is actually listed as an absolute, and on the next slide it's a relative contraindication. So hepatitis C does now have treatments for it, and there have been transplants in patients with, there have been lung transplants in patients with HIV. Those are high-risk transplants, though, and they are rare, still rare today. So the other relative contraindication, which I get asked most often about, is age. So I get asked this question both by patients as well as physicians. So the age greater than 65 is considered a relative contraindication. The reason it is considered a relative contraindication is that as we all get older, we have greater risk of having other problems. And so in particular, the way that we worded this for the consensus statement was that we were particularly concerned about individuals who look like that they have a low physiologic reserve. Other physicians might use the term frail. So making sure that we can really get someone through the big procedure and get them to be able to rehab effectively and have a good outcome. We were also clear to say in that consensus statement that there is no clear upper age limit, but that being over the age of 75 seems that it's unlikely that one would be a candidate. There are individuals in the United States over the age of 75 who have undergone transplant, but they are a rare event for sure. So this graphic is the number of transplants separated by age in the United States. So if we just look at 2017, as I said, there's about 2,500 transplants. The vast majority of those transplants are individuals who are, in terms of the largest group, is individuals 50 to 64. But you can see the next highest group is individuals over the age of 65. The number of individuals who are over the age of 70, unfortunately I cannot tell you that number, but I think that that number is somewhere probably around 10 to 15% of this 819. That's a little bit of an educated guess based on data that I know from back in 2013. So it is becoming more common. Also, you see in 2006 we really didn't do a lot of transplants in individuals over the age of 65. Every year it has increased, and from 2016 to 2017 it took another big jump up. So how does the process start? And this is where I think you all can really, really help us out. So there are differing practices for transplant centers. Transplant centers, as a general rule, follow kind of one of three possibilities when they get a referral. They might say, well, let's have you just come for an initial clinic visit. So that's a visit with the doctor. We talk to you. We make sure we understand all of your medical problems and that we have the data. And then a decision is typically made at that time. Should we do more evaluation? Should we try to treat your advanced lung disease maybe differently than it's been treated so far? Or do we think that by looking at you that we can tell you that with some of these absolute contraindications to transplant, we're sorry, but we think that this is not an option. A mini evaluation, many centers do this, is that they look at your information when you're referred and they decide to do a few tests. Maybe they do some heart tests or they do some CAT scans of the chest, try to get a little bit more information, and then they talk to you and make sure that they have all of your records and make a decision. The last option is to do what most centers call a full evaluation. So a full evaluation typically finishes with being presented at a selection committee. So the full evaluation is 4 to 5 full days of testing. It includes all sorts of blood work, lots of pictures, and we are looking at, oftentimes we're looking at things like blood flow to the lungs, CAT scans of the chest, the size of your lungs. We do like bone density testing and also images of the spine to see if there's any evidence that there's significant osteoporosis. We do breathing tests, which many of you are very familiar with, doing a full set of breathing tests and a walking test. And then if there are any other questions that arise, we might pick additional testing to do. So that might be looking at like blood vessels in the neck or some other specific tests. As part of this testing, a left and right heart catheterization procedure is most typically done, particularly individuals over the age of 40 as a general rule. They're going to get a heart catheterization. We then do a ton of consultations. Those consultations include the surgeons, the medicine doctors, the financial people, dietitians, pulmonary rehab. You meet a lot of different people who are actively involved in the process after transplant. And then when all of that is completed, we sit down and we talk about you as a group, and that is called the selection committee. And at that selection committee, decision is made as to whether someone is a potential candidate, not a candidate, or maybe we need to do a few more things before we consider them a candidate. So health maintenance, I wanted to take a minute to just stress this. So health maintenance is one of the key components of helping us figure out whether or not you're a good candidate. As I mentioned, individuals are at increased risk for cancers with these medicines. So we want to make sure that everyone has gotten their cancer screening totally and completely up to date. Dental exams are really important, making sure that there's no significant gum disease and that your dental hygiene is up to date and that things are okay. Osteoporosis is important, and then losing or gaining weight. So individuals can be either underweight or overweight, but if your primary care doctor identifies this, while you're trying to get into the transplant center, really working on that and participation in a pulmonary rehab are two great ways to help the process move a little bit faster. And the top line that I saved for last, optimum treatment of chronic conditions. So this means that if you do have a diagnosis of diabetes, that your glucose is very well controlled and you're up to date and you understand all the things that you can eat and not eat and what the medicines are doing for you. So really being a well-educated patient who is maintaining any chronic problems that you have is a key component to making sure that a transplant center is not going to be identifying problems on that evaluation. Another thing that is unfortunately an absolute truth is that transplantation is a very expensive process. Medications are very expensive. We use immunosuppressant medications that can be expensive, but typically that is one of the cheaper things because it's covered by Medicare. But we also have specialty medicines that we have people inhaling that can be very expensive, antiviral medicines which can be very expensive, and antifungal medicines. So the importance here is just knowing that as part of a transplant evaluation, we do look at all of this stuff. We want to make sure that folks are prepared for the economic impact of a transplant. And this includes most often, most people do not live immediately adjacent to a transplant program, so you may have to relocate for 3 months. If you do, all of those costs are incurred because most folks keep their home and so it increases their living expenses significantly. Caregivers, and I really think for caregivers there's two big impacts. One is oftentimes caregivers may be working and may be the primary modality for insurance coverage. If that's true, then we have to make sure that we have a plan in place that allows them to really help out but also allows them to return back to work. So this can mean that we have to ask other family members, friends, church members to help out in that early post-transplant time, providing support and care for the transplant recipient. And the psychosocial impact of that can't be underestimated. I do think that it is extremely difficult to ask people to relocate, especially when they're not feeling well. So many programs incorporate behavioral medicine and a strategy to make sure that we're doing everything that we can to keep people thinking positively, and so that they can have as good a mental positive outlook and outcome in addition to the physical outcome after transplant. So who do transplant centers want to list? So the ideal candidate to list for transplant is someone that we know has a very high risk that they're going to get into trouble in the next 2 years. If we can pick out that group of patients, then we have a very high likelihood of having a real survival advantage for those patients. And so part of that is also individuals who really have a hard time doing their activities of daily living. They have to be able to participate in pulmonary rehab, but most folks are not independently living. They have supplemental oxygen. They need help to get around. And then we want an individual who is medically well, as I've said several times, but again, that we know that their psychosocial background is going to ensure that they have the best opportunity to do well after transplant. So why not just wait and hold on until I really need to be listed? Why should I go there early? Well, particularly for patients with idiopathic pulmonary fibrosis, but I think for any patients with interstitial lung disease, this kind of graphic shows different course of disease, and I think that this can be a real challenge. So there are so these are respiratory function and symptoms on this axis here, and then this is time going out this way. So we definitely see patients with idiopathic pulmonary fibrosis that are kind of doing okay. Every time we see them, we think they're still doing okay. Maybe they have a little bit of decline over time, but it can take a long time for that to happen. We also, unfortunately, see patients that really rapidly decline. And we see a not insignificant number of people who look like they're just like this group that's going along fine, and then something happens and they become a rapid decline patient. Because this something, oftentimes it's an infection or some other medical issue, this something is often not predictable. I think talking about transplant back here, when you're doing okay and you can really hear everything there is about transplant and make an informed decision whether this is something for you, it is much better to do that back here than it is to try to do it down here when you're really sick. So what do the physicians look at when they're trying to figure out if they want to list you? What is that list of physical factors that makes us say, oh, we're really worried about you? Well, one thing is if your breathing tests are changing significantly over 6 months of follow-up, that makes us very concerned. And we look at the forced vital capacity in particular as a measure of that. So how much air you blow out from the top of your breath to the bottom of your breath. Your 6-minute walk test data is really important. If you are going along and you don't need oxygen, you don't desaturate to less than 88%, then we, as a general rule, think we're doing okay. As soon as you start to show evidence that you need oxygen, then that is a risk factor that things can change and be worse for an individual. In addition, most or many centers take a look at echocardiograms or ultrasound of the heart, and we're trying to estimate the pressures that are in there, or we'll do a right heart catheterization, and if those are abnormal, that's a high-risk group. And absolutely an individual who is hospitalized because of their breathing, that is a very high-risk patient. The challenge in that is that oftentimes when one is hospitalized for that decline in their breathing, they can be very, very sick. So again, knowing about transplant and having a relationship with a transplant center at that time is of real value. So I also have folks who come and say, but wait, I'm using oxygen, I'm like physically fit, I feel like I'm ready, but my transplant center said I'm too early. So why is that? So I'm going to just spend a couple more minutes here talking about how transplant centers list and how it can vary from place to place. And unfortunately, this can be really frustrating for people because they can't. It's very hard to understand why in one part of the country something can be done one way and it can be done differently. So I'm going to try to help clear that out. So this is a graphic that shows what is the percentage of patients that get transplanted before the time on the line there. So on this line here, this is people who have been transplanted within 3 months. And I think that there's some really encouraging things here. If you notice, the line's going up. So there's more and more likely that people are getting transplanted faster. That means we're doing more transplant, and I think that is a good thing. So it's about 50% of the group gets transplanted within 4 months, so just a little bit less than that at 3 months. You can see that the vast majority of people are transplanted within 1 year. So there's a big difference between waiting 2 weeks and waiting 1 year. And so how can there be such variation? Well, the listing of people is dependent on how sick someone is, and it also depends on where you live. And this is something that we're actively working on with the United Network of Organ Sharing, of how to make sure that we're allocating organs appropriately. So this is a map of the United States that shows what is the likelihood that, or how successful is an area at obtaining deceased donor lungs. So for every 1,000 people that die, how often do we get a set of lungs? And so you can see that this varies from place to place. So the darker areas are centers that are states that do a little bit better in this metric, are able to provide more lungs than states that have less lungs. This graphic takes a look at what's the likelihood that someone's going to get transplanted within 1 year. So you can see that there is some variation. So North and South Carolina, we've got 100% likelihood that someone will get transplanted within 1 year, and some other areas it's less than that. So as I said, the United Network for Organ Sharing is actively working on a process to try to make sure that we are providing every opportunity for folks to get transplanted appropriately, and for it not to matter on where you're listed or where you live. It is a complex process, but some of this is what can influence whether a transplant center thinks you're ready today or they think you're ready in a month. Because if we think you're doing okay, you might be sick, and we think you're doing okay, but if we put you on the list and we are transplanting very quickly, we want to give you a little bit more time to rehab. We want to give you some more time with the lungs that you have. On the other hand, the advantage of being in a program like that is that if you're very sick, you're going to get transplanted quickly. For other centers, it may be that they want to give you every opportunity because there are things about you that maybe it's harder to find a match for you. So you may be less ill, but we want to make sure that we have lots of opportunity to have organs that are going to come up so that we can finally find a match for you. That also can absolutely influence when we list people. So the listing practices of a center sometimes are hard to figure out. I think that the best strategy in all of this is, if you're interested in transplant, to ask your doctors, and then to go ahead and ask them to be very clear in why you're not a candidate, and then ask. It's always okay to ask a transplant center. Every transplant center in the United States is going to tell you it's always okay to ask them. So early referral is kind of a key. I think if we can have these conversations when people are feeling well, it means that you're really going to have an opportunity to hear what it is that we think we can do for you, and also gives you an opportunity to be able to ask all your questions and really consider whether it's something for you. Age greater than 70, it's true that there are centers that are absolutely doing patients who are over the age of 70, and as a general rule, age is not going to be the only thing to exclude you. But remember, individuals over the age of 75, that is more rare. So you really have to ask your local transplant center, or maybe ask your pulmonologist, is there a center that is going to be very interested in me? Where's my best shot at doing this? The transplant evaluation does take some real time, and so working on that and ensuring that all of your health maintenance is up to date and that you're taking care of your chronic medical problems, that's huge. Participating in pulmonary rehab is a key component for all transplant centers across the United States, and the goal really should be people to have a healthy weight. We want everyone to have a healthy weight. We realize that there's huge challenges in that, but if you can start working on that even before you see the transplant center, you will be way ahead of the game. Transplant can be difficult on the finances and family and on your mood, and I think doing everything that you possibly can to ensure that you're ready for that and using all the resources that transplant centers have for you is a key to overcoming that. And then again, transplant offers a second chance for the right candidate, and I definitely think is really cool that picture of Lorcan doing that 9.5-mile run. Lorcan has just truly gotten a second chance from his transplant. So I think with that is where I'm going to end. We have like 3 minutes, so if there's any burning questions, I'm happy to do my best to use up all of my time, and I really appreciate everyone's attention. And 3 people are typing, which is cool. Sure. So the question is, can you discuss refurbished lungs and high-risk lungs? So I tried to allude to this in the beginning. Really, as a general rule, all transplant centers are very interested in taking lungs that can work. And so there are kind of wide ranges of what are quote-unquote acceptable lungs. So we do have some new technology, the ex vivo technology, where we can put the lungs onto a circuit. That technology right now is, in my opinion, a good way to maybe assess lungs. But what we're really hoping for in the future is, like you said, to refurbish them and make them better, be able to intervene on lungs and make them even more functional. If we can do that, we'll really increase the donor pool. I think that's awesome. Temple's a great transplant center, and that's fantastic. And I wish you all the best of luck with that evaluation. If my lungs have IPF, will the new lungs get IPF, or is death expected before that would happen? So there are pulmonary fibrosis disorders that can recur in the transplanted lung, but for individuals who have idiopathic pulmonary fibrosis, there has not been a clear documented case of recurrence. And I do think that your hypothesis or guess as to why, I do think that that's part of it. You know, pulmonary fibrosis tends to happen in people who are much older, so we're able to keep your lungs running, and even 20-year survivors after a diagnosis of IPF don't have recurrence. Oh, so the list, so there's actually 70 or 80 transplant centers. So the best place that you can find a list is to Google lung transplant and your location. If you do that, you will get the closest center to you. The other site that you can look at is the United Network for Organ Sharing. We'll have a list, and I also suspect that the Pulmonary Fibrosis Foundation site can help direct you. Many of the ILD centers on the Pulmonary Fibrosis Consortium, we are transplant centers, and if we're not, we have a close relationship with transplant centers, so that's a great resource. Can we get a copy of the text that you just talked about and a copy of the slides? So that one I'm going to defer to Lori to answer at the end. That's awesome because I do not speak French, so I am glad that I was nice and clear for you. And then I am going to, the answer for Esbriet, I will tell you is that we typically do not continue that after transplant. The pulmonary fibrosis is gone, and so the need for Esbriet is gone. And then the last question that I'm going to answer is how to choose a center. I think that there are many different ways to choose a center. That it should probably start with your primary doctor, your primary pulmonologist, and asking them what they think. I think it is hugely, hugely important that no matter what transplant center you decide to go to, that you feel really comfortable with the physicians and the staff that you meet. So it is not unusual for all of us to have interactions that are maybe not positive. I think if you walk into your doctor's office, you should feel comfortable. That's my #1 goal. So I would tell you that there are choices. You can look at regional centers, but starting with your primary physician and asking them what they think is a great idea. And then I will answer the last question, what if you only get one lung? So for the Esbriet, it's true that the fibrosis can progress in the native lung, but patients who undergo a single lung transplant, they do functionally very similar to patients who have 2 lungs, and as a general rule, that progression of the fibrosis doesn't make people do worse. So that is, an Esbriet is very expensive, and given all the other medications that you have to take, that's also a factor in why we don't continue Esbriet after transplant. And so with that, Lori, I'm going to let you answer the question about where they can find the text here, the slides, and all that, and then I think we're done.
Sure. I want to thank Dr. Whelan for this fantastic presentation. The webinar will be posted on the PFF website, which is pulmonaryfibrosis.org, and also will be posted on our YouTube channel, which is Pulmonary Fibrosis Foundation, so you can find it there. I want to say thank you to our sponsors, Boehringer Ingelheim and Genentech, for their generous support of our webinar series, and we will see you next time. Thank you.